First, serotonin syndrome. Consider the agitated 32-year-old patient. She demonstrates tremor, hyperreflexia, and bilateral clonus. She is tachycardic and hypertensive. Symptoms developed within hours of adding tramadol to her SSRI regimen. The underlying mechanism is excess serotonin, particularly at 5-HT2A receptors. The classic triad includes neuromuscular hyperactivity, manifesting as tremor, clonus, and potentially seizures, altered mental status, including agitation and delirium, and autonomic instability, characterized by diaphoresis, tachycardia, hypertension, and hypothermia. Notably, onset is rapid, typically within hours. Key diagnostic features are hyperreflexia and clonus. Management involves immediate discontinuation of all serotonergic agents. Administer benzodiazepines for agitation or seizures, provide intravenous fluids, and consider cyproheptadine in severe cases. Active cooling is essential. Paracetamol is ineffective, as this is not a typical fever. Now consider the second patient. A 28-year-old male, recently commenced on haloperidol. After several days, he develops confusion, fever, and pronounced lead pipe muscular rigidity. Deep tendon reflexes are reduced, and creatine kinase is markedly elevated, often exceeding 9,000 units per liter, with rising serum creatinine. This presentation is consistent with Neuroleptic Malignant Syndrome. The pathophysiology involves dopamine receptor antagonism, primarily at D2 receptors. Onset is typically subacute, developing over several days to a week. Neuromuscular findings include rigidity and bradyreflexia, without clonus. Mental status changes range from delirium to stupor. Autonomic dysfunction is also prominent, with labile blood pressure and pronounced diaphoresis. Management requires immediate cessation of the antipsychotic agent. Initiate aggressive supportive care, including intravenous fluids, active cooling, and intensive care if indicated. Dantrolene or bromocriptine may be administered to counteract dopamine blockade. Let us compare the two syndromes directly. Serotonin syndrome, rapid onset associated with serotonergic agents, hyperreflexia and clonus, mild elevation of creatine kinase, mydriasis, treated with benzodiazepines and cyproheptadine. Neuroleptic malignant syndrome, subacute onset associated with antipsychotic medications, rigidity and hyperreflexia, marked elevation of creatine kinase, normal pupillary response, treated with dantrolene and bromocriptine. In summary, clonus is indicative of serotonin syndrome. Rigidity is characteristic of neuroleptic malignant syndrome. Both conditions are medical emergencies. Prompt recognition and intervention are critical. Early identification, differentiation, and management are essential to patient survival.